In the Senate, we used to have red lights, green lights, and yellow lights. We don't have the lights today, but I would just ask our presenters if they could to be cognizant of the time constraints under which we're working. We've got a very, very aggressive schedule, and with such excellent presentations, I hate to cut them short, but if you could be cognizant of the limitations we have on time, I would be very appreciative. We're going to go quickly to our third panel. The third panel theme is the evaluation and application of what works best. I think we've had some conversation about that with earlier presentations, certainly, but we have four people who are in a very good position to know what works best. John Roberts is the Senior Vice President and Chief Information Officer of CVS Caremark. John Santa, Dr. Santa, is a healthcare consultant for Consumers Union. We're very pleased he could be here. Kathy Budo is the Vice President of the Healthcare Policy for Government Affairs for Johnson & Johnson. And Jeffrey Kang. Dr. Kang is the Senior Vice President and Chief Medical Officer for Cigna Healthcare, and we're very pleased that Dr. Kang could be here as well. I don't see everyone up here.
She went to the ladies' room.
Okay, well, very good. Why don't we let us start in order as they are seated, and we'll begin with John Roberts.
Thank you, Senator. Good morning. Very happy to be here to participate in a dialogue about improving quality and value in our healthcare system. I believe we can do both. I don't think it's an either or. And I'm going to talk this morning about e-prescribing and how this fits in with our theme of this forum. This is a train that has left the station, but it's also an example of where we need to get more people on the train. I'm going to touch for a few minutes on personal health records and then talk about how Washington policy can really play a role in moving us along in this area. So let me just start by talking about who CVS Caremark is. CVS Pharmacy, 6,300 stores, coast to coast. Caremark, which merged with CVS about a year ago, is a PBM, pharmacy benefit management company, manages prescription benefits for large employers, health plans, and the federal government. We fill or manage 1 billion prescriptions a year, and you can see in the areas that we support in pharmacy services and healthcare, we are a leader in those areas. So let me start with e-prescribing and share with you what I think is a unique and comprehensive vantage point of this very important area of quality and value in healthcare. And if you start in the lower left corner with Minute Clinic, we have nurse practitioners that write prescriptions for patients that have acute conditions. They write e-prescriptions that are transmitted to a pharmacy, electronically transmitted to a pharmacy of patient's choice. If you move up to the pharmacy benefit management, or PBM, they provide plan design, formulary, eligibility information, medication history to the physician practices, and they do that via RxHub. We actually own a company called iScribe that is a physician software e-prescribing company that's deployed in 2,500 physician offices, and we've transmitted electronically over 14 million prescriptions. Our retail pharmacies receive these prescriptions electronically. We fill them. When we need refill requests, we electronically transmit those requests back to the physician's offices to get authorization to refill. We're a founding member of RxHub, which works with all the payers to provide medication history, eligibility, and formulary information. And we're also founding members of SureScripts, which is the connectivity between the physician offices and pharmacies. So e-prescribing clearly solves many of the quality issues that we see in healthcare. Patient safety first and foremost. 1.5 million injuries that are drug-related, 7,000 deaths each year. E-prescribing does a lot to advance quality in this area. Patient and payer cost. This is quantifiable savings, and I think is a real justification to create incentives for physicians. For generics, we see a 600 basis point improvement in generic dispensing rates. Physicians know that generics are available. There's thousands of drugs. How can they keep up with them? We see a 550 basis point improvement in formulary and preferred drug cost. That translates to, on average, an $8 reduction in the average cost of a prescription. So solid and real financial results. Then there are other benefits, improving outcomes through compliance and persistency. We know that's a real challenge with compliance with medications. Physicians reduce costs administratively through using e-prescribing, patient convenience, and emergency preparedness. So adoption is growing, and we project between 2007 and 2008 a growth, it's going to grow by 3x. But it's still a very small percentage of all prescriptions written, only 6%. So when we look at this landscape, it's a mixed story. Pharmacy's done a lot of work over the last several years investing in technology. So we have 95% of the pharmacies that are actually capable of accepting electronic prescriptions. All states now allow e-prescribing. But then when you look at the physicians, you can see that adoption is low. Only 29% of physicians have access to electronic prescription software, and we only have 6% of the physicians that are actively prescribing electronically. So our primary challenge is physician adoption in this space. So what do we see from our vantage point? The number one reason physicians cite for not going with this technology is cost. And I hear that in a lot of forums and meetings like this. But the reality is there are several solutions that actually give this technology away. We give it away at iScribe. Permatix gives it away. Nepsi gives it away. We have feet on the street targeting high prescriber physicians where we want to give them the capability to e-prescribe, and we only have 1 in 10 doctors that take this. So I don't buy the fact that cost is a barrier to adoption. What are some of the other barriers? Lack of incentives. People just don't like to change. If we don't give them an incentive to change, they're going to continue to do the same thing. Controlled substances is a barrier. Workflow and training in physician's office. And then we see confusion from the doctors around EMRs and standalone. We have an error here. I'm going to click Don't Send. You can send that later. And
Electronic transmission.
Exactly.
okay, let me keep moving. It's a new way to speed up the presentations. So there is confusion around doctors between all the different options, EMR and standalone prescribing solutions. So there's an opportunity to do education. Let me move on and spend a minute on personal health records. Why be excited with this? It's a way to increase consumer engagement. Why be cautious? We got security and privacy concerns. There's a lot of stakeholders that are interested in this space, employers and payers. We have new players entering this space, Google and Microsoft. CVS Caremark is actively engaged in supporting this. We want to see consumers get more engaged. So what can be done in Washington to promote health IT? We need to create incentives for physicians to e-prescribe under Medicare. We support incentives that we see in the e-meds bill. We think that if we provide incentives, physicians will adopt. We need to eliminate the barrier to e-prescribing for controlled substances. 20% of the prescriptions are controlled. We can't send them electronically. The DEA and Department of Justice are concerned about fraud and abuse. If you look at the financial industry, totally electronic, they're in a better position today to detect fraud and abuse than they were years ago when they were paper-based. We can do the same in this space. We need to create grants and tax incentives to encourage broader adoption. Ensure strong patient privacy by enforcing existing federal privacy laws, and make sure new players that enter this space are covered by this. And support private and public partnerships on standards including security. So obviously e-prescribing and health IT is a beginning. We're beginning to have dialogue at CVS Caremark about health care more broadly. We're still developing formal positions, but these are areas that we think need to be included in the conversation: patient access to catastrophic coverage, coverage of preventive services, and creating a pathway for generic biologics. So in conclusion, we believe the time is right for change in health care. We believe technology should play a key role, but we need to create incentives to drive adoption. And we're very happy, CVS Caremark, very happy to participate in these discussions at all levels. Thank you.
Thank you, John Roberts. Dr. Santa.
Thank you. Consumers Union appreciates being invited, and I certainly am excited about being a part of this presentation. Last night I spent most of the night grading second-year medical student papers. It was a disquieting experience. These are students who within minutes when they participate in the healthcare system can see what a mess things are. I think particularly for us at Consumers Union, it's a problem when there's lots of conflicts of interest and it's a mess. You all are experiencing this, you're seeing it, we've heard about it this morning. There's lots of barriers to changing this. We're particularly interested in comparative effectiveness research, and it's expensive. Getting data, aggregating data is hard to do. Data is inconsistent because lots of well-meaning folks are making efforts to get it, and so there's inconsistencies. Some folks are resistant to sharing their data, for good reasons, some not so good. Doctors are particularly concerned, consumers are worried, and as we survey and do focus groups, you can see consumers beginning to be disquieted about learning how this actually works. You mean my doctor really isn't paying attention to the evidence when they're taking care of me? Since 1936, Consumers Union has been involved in health, and actually we're excited about the opportunities that are on the horizon. In 1936, in the first edition of Consumer Reports, we were skeptical about a fizzy aspirin called Alka-Seltzer, toothbrushes that had various angles in them, and we pointed out the dangers of lead in toys. How much has changed? What consumers want is trustworthy, easy to understand, and actionable information. I think they would prefer to avoid commercial agendas, advertiser influences, and financial relationships. They want to be involved from the outset, including in the choice of topics for evaluation and what works in terms of translating information. They want us to be working with advisors and groups who are independent and unbiased. They want ratings. They want comparisons. We've given them some. We'd like to give them more. The one we're most excited about is the one we've done most recently, which has to do with prescription drugs. Best Buy drugs. Best Buy drugs started with the kind of information that we need. A credible source of unbiased, rigorous information analyzed in an island that was free of conflicts in an evidence-based practice center, a concept that John Eisenberg and Carolyn Clancy are responsible for. It wouldn't have happened without John Eisenberg's idea and Carolyn Clancy's support. Consumers Union was able to take that data and then intensely look at it using inside and outside consultants and peer reviewers. They then took that information and did what they're good at. They summarized it, they rated it, and they used symbols to communicate its importance. And surprise, what Consumers Union found was a bit different than the folks who were selling these products had told consumers they thought. That's not bad. That's the reality of markets. You need balance. That's what we want to bring. Millions of people have viewed this information on the internet, and it works. We have a relationship with Medco in which they distributed this information to large numbers of their users, and substantial savings resulted. The Wisconsin Education Association did the same thing. We're trying to get better organized, and to do so, we now have a dedicated website to health. You know, we're ambitious. We hope sometime in the future folks are as attracted to Consumers Union and Consumer Reports for health as they are for autos and electronics. And we'll give it our best effort. We need some help. You know, if you went to Yonkers, you would see 51 laboratories filled with these tinkers, these independent engineers who test devices and products. That's hard to do. How many of you would volunteer to be a mystery patient who just before they're about to put that stent in says, "Whoop, I'm from Consumer Reports, let me out of here." That concept doesn't quite work in health as frequently as it does in other products and services. So we're prospecting for good sources of independent data about comparative effectiveness. We want to use the expertise we have at translating information to make this information more effective. We think that might help then for comparative effectiveness information to be used in other ways, in benefit design and for rewarding providers, and to make cost sharing more targeted, more of a fine tool than it is now. Pretty blunt tool now. I think to make this work, it's particularly important that we look at doing this like Consumers Union has looked at doing their work. And that involves a difficult step, eliminating conflict of interest at critical decision points. And for us, that means training, research, regulation, purchasing, and at the point of care. We're prospecting for these conflict-free, independent islands of health research and delivery. We know they're out there in evidence-based practice centers. We know they're out there in Cochrane groups. We think they could be out there in a variety of other places. Those are the kinds of independent laboratories in health that consumers would like this information to start from. Consumers are interested in these efforts being transparent so they can understand them. I've been surprised watching focus groups and looking at survey data how many of our consumers really want the detailed information. They want to know, so how did you make this ratings decision? They want the details. And you know, we have the information to get it to them, but it means in terms of health information technologies, we have to be willing to turn those tools on. At my own institution, at OHSU, I was disappointed when I heard that they turned on all the financial pieces of the electronic record, but didn't turn on the registry piece. I'm going to do that later. There's lots of great information technology that would support comparative effectiveness, safety. We just need to turn it on and look at it. Thanks.
Kathy Butta.
Hey, thank you very much for inviting me, and I'm probably going to have the most terse, I hope. People always promise that and then don't deliver, but the most terse presentation, because I was told, be very practical. I'm going to focus on three things. One is comparative effectiveness. The second is a risk-sharing scheme, which is not a bad word in the UK. A risk-sharing scheme that we engaged in as Johnson & Johnson in the UK involving a product. And the third is drug safety monitoring. So I'm not going to really dwell on this. I think you probably know that Johnson & Johnson supports comparative effectiveness and believes that we need to move forward in this important area carefully. I do want to highlight two things, though. One is people don't often think that this is a good thing for product development companies. We think it is. We think that it is a way for developers of products to really differentiate truly innovative products. So we see it as a benefit, potentially, to stimulate the right kind of research. And then if you look at my last point, we think that the research investment, if we truly engage in an enterprise of comparative effectiveness, will essentially follow higher value treatments. But in order to do that, the rewards have to be there. And I put that out there because as people talk about comparative effectiveness, they rarely talk about the incentives that are going to be needed to actually stimulate research into even riskier areas where potentially your returns are going to be much lower. So please keep that in mind. That could be streamlined approvals, higher reimbursement, et cetera. Okay. One of my big concerns about comparative effectiveness is that, and I was involved in designing, I think Chris Castle mentioned the RVRVS back in the 90s. We had high hopes that the RVRVS was going to shift payments to primary care physicians. I think everybody at this table probably remembers that discussion. And we're now back talking about how do we enhance and further empower the primary care physician to be more of a sort of medical home. So back then, I remember people saying, we've solved that problem. We haven't solved that problem. This is not going to solve the cost problem. And I think when I hear people talk about comparative effectiveness, they often speak of it as if it is a cost-saving, in some sense, societal-saving measure. So just a word of caution there. Real concern that population-based decisions that come out of, that are implied by, that lead to, say, benefit package restructuring and so on, could trump individual patient needs. And we don't have time to talk about it here, but the whole issue of measurement and how we measure value, as I think Denny Cortese so eloquently laid out, is critical to figuring out how these decisions actually get implemented. So that is a concern. And of course, there's the issue of cost and the fear that, that cost savings are over time, which we agree should be more of the metric than costs for an input or for a procedure, that will be the debate that goes on. And again, really support the way Denny Cortese looked at it. I was struck by John's comment about consumers' fears. Pharmaceutical, medical device, the product development industry has probably just as much fear about the lack of transparency. We actually think it's not about getting access to our data. We're now concerned that payers have much more data than we do, and that we will be locked out of getting access to information that actually could improve product safety or even suggest new areas for research. So I was asked to sort of try to talk about what is the best way to go about this. And I have to put at the top trust building. There's tremendous fear among all the stakeholders. And rather than, I guess, a conflict-free zone, John, I would say we may need something more like a conflict-inclusive zone where all the conflicts are obvious to all. So that's critical. The other thing is we really need incentives to stimulate clamoring for comparative effectiveness. How that happens, I don't know. But if you want real comparative effectiveness to go on, there has to be a real clamoring for it. Let me move to the risk-sharing Velcade case. And this is probably the crux of what I wanted to communicate to this group. Velcade in the UK, in a final NICE recommendation in October of 2006, was recommended not to be covered by the National Health Service. And this was a treatment that basically was the only treatment for multiple myeloma. And the committee actually concluded that it was clinically effective, but not cost effective. The concern among people in England was that it was already available in Scotland, Wales, and Northern Ireland. And the media and patient groups started getting very energized around what a death sentence NICE was essentially proclaiming. The issue for NICE was uncertainty. NICE could not tell, based on the data that existed, which patients would truly benefit, and they were concerned about paying for a lot of unnecessary care. And that's what drove an unfavorable cost-effectiveness decision. Our company appealed, but we were very concerned because prior to our appeal, only one other appeal had ever succeeded in overturning the guidance. So as an alternative, Johnson & Johnson proposed a risk-sharing agreement. So this is the agreement. NHS will fund the treatment at the first relapse in patients who achieve a complete or partial response during the first 4 cycles of treatment. And there's a way to test for this, and that makes it a much more accountable process. Patients who fail to respond will be discontinued on the treatment, and the company will provide a complete rebate or free stock direct back to hospital units for patients with less than a partial response. And I have to stop here and say this was, people call this a money-back guarantee, and I think in a sense it is. We see it as an interim bridging measure to get the product out to patients on a limited basis in order to actually have it in real-world use. The alternative of not having it in real-world use at all was pretty daunting. So we went for this. I just want to point out it's not, in our view, the ideal performance or risk-sharing agreement, and there are many others. And those would include an agreement we reached in France with drug-eluting stents, where we actually agreed with the government on a set of parameters, restenosis rates in patients, and in other cases with antipsychotic medications, a compliance rate. These are the kinds of measures that I think companies feel a lot more comfortable in terms of an outcomes guarantee than every patient who doesn't respond will provide a rebate for. The other thing I just quickly point out is that there are many other compliance guarantees or outcomes guarantees, guaranteed savings as a result, having to do with deferred hospitalizations or other things. And in the U.S., coverage with evidence development, which Mark was so instrumental in developing, which is a way to accelerate access to important technology, but gathering real-world data on a limited time frame basis. Again, those are, to my mind, preferable to a money-back guarantee, which I don't think we expect anywhere else in the healthcare system. Just one last statement, because I'm out of time, about drug safety monitoring, which is the other area of evidence that we are deeply involved in. I think you're well aware that the FDA has new authority in this area. This slide points out how difficult it is in pre-approval trials to really gather evidence on adverse events, and that we require tremendous cooperation with FDA as the product is out in the marketplace and used by patients. One thing I would point out as we look at a learning healthcare system and post-marketing surveillance is really important, is that if we're going to really have a learning healthcare system, we really need to be able to identify signals not just of safety issues, but also how do we improve targeting of patients? How do we improve our understanding of appropriate use of various treatments? And we see this as a limitation at the moment in the way that people are currently thinking about this interoperable linked information system. I'm going to stop by just saying that I think the issue of building trust, a conflict-inclusive zone, and better targeting, which I think is really part of the solution, and it involves biomarkers and other methods, risk sharing, et cetera, are keys to a more efficient and more responsive and accountable healthcare system. So thank you.
Thank you, Kathy. Our final panelist, Dr. Kang.
Thank you, Senator Daschle. I'm here representing America's Association of Health Insurance Plans, but also Cigna Healthcare, which is the fourth largest insurer in the country. We cover over 12 million lives. I'm going to, though, talk a bit about what the health plan as an industries are trying to do in terms of solving some of the problems that you heard around by quality. We actually would see three broad problems. You already heard them. First is the fragmentation and under-delivery of evidence-based care. And in this area, I'll talk about disease and case management programs and our gaps in care programs. Second is the wide variation of care that's being provided. We actually believe that there's a lack of competition on value, which you've heard about. I'll show some of our solutions in that area. And then third is the lack of individual incentives for health and wellness. I'm going to actually show Cigna experience and Cigna results, but I want to make sure that people understand that many of the other health plans are pursuing very similar programs. We, of course, think we do them better, but that's a separate discussion. In the interest of time, I'm going to skip this slide. So on the disease management side, the way we approach disease management is we actually align nurse care coordinators to really try to begin to create a system around the individual to help navigate the system and the various touch points and then negotiate the fragmentation. This is actually results out of a 2004 Health Affairs article that we've published on our programs. It was a case-controlled study. And in that study, we actually saw 7 to 12% improvement versus the control group on many of those evidence-based clinical measures. We also identified depression and intervened in these various disease states. We saw 90% satisfaction in member participation in these plans and an associated 11% decrease in medical costs. Now, I've broken these down by diseases and showed the associated readmission reduction in admission rates. I won't go through those. Now, on the provider information side, in Cigna, actually, this is available to our 12 million members nationwide. For hospitals, we actually show risk-adjusted quality scores based on actually the ARC mortality and complication rate measurements for 29 of the most common admissions, and then risk-adjusted total hospital costs. So that's the value proposition. It's going to be complications and mortality versus total cost of care. Physicians, the same similar approach for 21 of the most common specialists. High-tech radiology, nationwide price transparency, and ambulatory procedures here, 16 of the most common procedures. And then pharmacy, you actually saw already, we have very similar functionality as Consumer Reports, so I won't go into that. So this is available to our 12 million members nationwide. Let me just talk a little bit about what the opportunity here is if we actually designate hospitals on those 29 admissions as the high value ones. So those who are consistently in the top third on quality and on the top third of the kind of cost profile, we actually see 30%, we would see 30% fewer deaths. So if all of our members sought care to those 1/3 of the top performers, we would actually see 30% fewer deaths, 28% fewer complications, and 39% lower cost per admissions. Similar story on the specialist physician side, but basically a 4 to 5% improvement in clinical quality, a 29% reduction in readmission rates, and 8 to 12% lower total medical costs. This is just an example of what I pulled off the web just 2 days ago on the hospital side. So I took Washington, D.C. zip code, 2005, 2005, 25-mile radius, total hip replacement, and the 3-star is our best outcomes. So so here they have lower mortality and complication rates, and then you see the average cost for the total episode here. And obviously here the punchline is you could go to the top 2 and get the better quality, but at a lower cost compared to the second and third facilities. The third column on the right would be, actually in this situation, would be my out-of-pocket cost sharing. Okay. The last thing I wanted to talk about, now just by the way, we use that information not only to encourage members to seek care from those high performers, but we actually use that information as the basis for our contracting. So we begin to incorporate that in value-based contracting with our network providers. Finally now, on the Healthy, this describes a program through one of our divisions called V-Life. We actually published this last year, again, in the American Journal of Health Promotion here. But in essence, what we're doing here is using health risk appraisals to identify people who are at risk of a future event. They've not generated a claim. So, for example, we have a smoker who we don't have a claim for COPD. We identify those people. We actually intervene with online coaching and worksite health education. And what we were able to show here over a 1-year period of time is a 5% reduction in the risk, the high-risk people, and medium risk, all transferring to the low risk. That was associated with a 3.1% improvement in worker productivity and 2.2 improvement in the days lost or absenteeism, and with a projected savings of about $229 in medical costs. Quick word on medical, on HSAs, HRAs, these CDHP plans. Cigna, we're a little bit different in the industry on this issue. We actually don't believe they are the panacea We think that that's an option, but we actually go into this very cautiously. We take two principles when we go into these CDHP plans. Number one is we refuse, if the employer wants to use these as cost-shifting vehicles, we don't play. In fact, we've lost business on that basis. Our recommendation is at a minimum, what needs to be put into these plans is the actuarial equivalent, what they would have otherwise gotten. And if they don't do, if anything, we encourage more funding into those plans. Second principle, though, that we use here is that they need to be coupled with these disease management programs, provider transparency, and health coaching that I've talked about. It's not adequate to have people in these plans and say, look, you're on your own. And so when done correctly, these are the results. We actually see an increase in preventive care. We see the same evidence-based utilization. So we do not see people avoiding medically necessary care. We see an increase in the maintenance of chronic medications, in medications for chronic conditions, and then we see total cost reductions. And interesting enough, the last point, I'll get to the data here, is member cost sharing. So their total out-of-pocket is actually lower in the second year. So what compared to traditional plans, this is the fourth line, they actually spend less in these products because they're spending less in total. And so these are the results here. Okay, last thing is barriers or accelerators. You know, we're doing a lot of these. So from a barriers perspective, we really believe that we can, through these programs, create additional value and create affordability. I think the only barrier I'd highlight here is that there are limitations to our ability to offer wellness incentives, so we look for some relief there. On accelerants, you actually heard a lot of this already. The only one I want to highlight here is the second one, data aggregation and profiling efforts. At the end of the day, Cigna Healthcare does not believe that we are the right entity to be profiling or ranking physicians in hospitals. We actually think that that's not a point of competition for health plans. We would welcome a third-party independent source to do that, and then, quite frankly, our added value would be getting members and benefit designs to encourage utilization of the high performers, and also our added value would be pay for performance. So at the end of the day, I would really welcome a third party to really be the arbiter, really, of what is value, provider value in the healthcare system. Thank you very much, Senator Daschle.
Thank you, Dr. Kang. Thank you for a very interesting panel and your presentations. We are very grateful evaluating and applying what works best, and there are a lot of very thoughtful ideas. Again, to stay on schedule and in the interest of accommodating our final panel, I think we'll move now to our last three presenters this morning. The final panel has as its theme the benefit designs that maximize good health care. We have three experts in this field as well. Sally Wellborn is the Senior Vice President of Corporate Benefits for Wells Fargo. Louise Malone is the Administrator of the Service Employees International Union, SEIU. And Pat Kappas-Larson is the Vice President for Community and Professional Development at Evercare. We welcome our three panelists. We're delighted you could be with us. And let us proceed with Sally Wellborn.
Thank you very much, Senator. And I enjoy being here to speak. It is kind of interesting that of all the presenters, we're the only ones here, I think maybe SEIU, that actually writes the check for all of these things. So we have a very vested interest. Wells Fargo is a very big company. We're very old. We've been around a long time. We have over 300,000 Americans that we pay for health care, and we spend over $1 billion for that health care. We're all over the country. We're not very international. We have some international. We're all over the country. I don't have to restate the health care problem. We've talked about it all morning. We know what the health care problem is. We know there's cost issues, there are quality issues. But we've seen some excellent examples of when things are changed, improvements can be made. And that's a key element here. We recognize now that there are things that can be done that can improve health care. From an employer's perspective, though, what happens if nothing changes in the way that we administer health care, the way we deliver health care? And from an employer's perspective, we think that it could significantly impact our ability to be competitive in a global marketplace. We are going to have to make decisions around, do we pay for health care or do we pay for team members, for employees? Do we pay them a salary or do we provide them with a benefit health care? If we have to continue to pay for health care, then we may not be able to provide for employees. We may have more and more uninsured Americans, or we may have more cost shifting. So at Wells Fargo, we talked about what do we think we want in the healthcare system? What are our aspirational goals? And we thought about it from all the major stakeholders' perspective because we recognize that we are only one tiny piece in this wheel. We think about it from we call our employees team members. We talk about it from the team members' perspective, from providers' perspective, the hospitals, doctors, and then from a corporate perspective. So for our team members, the most important thing is we want to make sure that they have access to quality care. We're not just in this we're not just providing health care because we feel like we have to as a competitive reason. We want it because as a corporate citizen, as a part of the society of the United States, that it's important for us to provide for the health care of our team members. We want our team members to have information so that they can be good consumer. I couldn't agree more with the gentleman from Consumers Union. We want them to be able to experience an improvement in future cost increases. We want them to be able to get to work because being at work is a better quality of life. It's a better place to be. We also recognize that with 165,000 team members, 300,000 individuals, that we have that many stories. Everyone has a different perspective. They have a different cultural background. They have different needs. They have different ways that they buy things and the way that they do things. And we have to be respectful of that. A one-size-fits-all doesn't work for a company like Wells Fargo. For the people that are providing the care to our team members, we want them to appreciate the fact that our team members are have a place in dealing with the outcomes, that they're not just a puppet in this situation. And we want them to recognize that they have pressure on the costs, that they actually have an out-of-pocket cost, and every time they send them for another MRI or another X-ray or blood test, that they have a financial exposure there, and it's not somebody, big brother paying for it. The member, and virtually every health plan that an employer offers has some exposure each and every time the member gets care. We want the providers, though, to get paid for doing the right thing. We think they should have incentives. We think they should be rewarded for being better providers, and that they would then deliver to us better outcomes and greater efficiency. So at Wells Fargo, then, what our ultimate result from this would be that we would have that health coverage is part of the basic offering to support financial security. And that as a financial institution, it really does all boil down to the dollars and cents. That if you're spending all your money on health care premiums, or if you can't work because you're sick, and you can't put money in your retirement plan, then you've lost your financial security. And that's really the crux of the issue. We want them to have a very good quality of life so that they can, as I said, be at work, and that when they're working, Wells Fargo's making money. It's a win-win situation. We think that that the member, the patient, is really a catalyst to making the change. And I want to be clear that I'm not saying that consumer-directed health plan is the catalyst. I'm saying that the consumer, getting the member engaged, is an appropriate way to do that. A consumer-directed health plan is a tool to do that, but you can have consumers engaged in an HMO or any other kind of a plan design that you want to offer. We think that it will drive for people asking for transparency, and when Americans became incensed because planes were falling out of the air, something happened, right? When Americans become incensed and understand all the things that all the panels have talked about today, the variations in care, the lack of quality, all those kinds of things, then we'll actually see some changes. We think that when the patient has incentives to seek the right care, they will. Unfortunately, as Americans, we're pretty lazy about doing what's the right thing to do. We don't exercise, we don't eat right, and we maybe don't go to the doctor for our regular checkups. Sometimes we have to get that little nudge, and maybe it's a financial nudge. And we think that when, like I said, when the providers understand the members at risk, there will be some trade-offs. At Wells Fargo, we offer, as I said, we've got a lot of people. We offer a panoply of health plan offerings. We have HMOs, PPOs. We have a couple consumer-directed health plans. Every time we offer these, we make sure that preventive care is covered fully up front. We make sure that mental health is covered fully, separate and apart, and in addition to any other plan that they have. In the consumer-directed plans, we have two because we're trying to offer a variety, but we always have first dollar coverage. And within the plan, we have incentives to get the right care. So for employers, what we can do is we can pick the right plans to partner with, and we can make sure we hold them accountable. So we can pick Aetna, Cigna, United Healthcare, 100, Kaiser, all the different plans we can choose from. We want to make sure that our employees, our team members, have a way to select between these, because being respectful of their differences, we have to give them some tools to make some choices. We can tweak on benefit design, and then we can work with all of you to change the system. We look for the best providers, and we try to hold them accountable. We look for strong networks. We look for good care management, et cetera. They have to be able to pay a claim right. And then we hold them accountable by financial guarantees, performance guarantees, et cetera. Just a quick highlight on this tool that we provide to our team members, and it's a first effort. We've had it for a couple of years. We actually, the Pacific Business Group on Health initiated it. We work with them on it. And it's a tool where the team member that's looking for what is the right plan for them can, on many dimensions, ferret out the differences between the plans. Because most of the time I go out and I talk to team members and they don't understand what the differences are. It's so funny because I've been around a long time, and I remember when we moved from the old PPO world to the HMO world, and people didn't get that. Now the movement from HMO to CDHP is that same friction time. But we're trying to, we have this tool where they can go and they can understand their premiums as well as their out-of-pocket costs, and understand both of those in how they influence each other. They can see which doctors are in the plans. They can see, we provide quality ratings of the plans on a number of different dimensions. In CQA, we happen to use Hewitt for some quality indicators, and then we also survey our team members, and we spit back to them exactly what they told us as far as their satisfaction with the health plans. What features are in the plans, what care management programs, but anyway, a place for them to bring together into a single picture which of the plans that we offer is best for them. We can tweak around with benefit design all kinds of ways. We can encourage member behavior through prescription drug design, and we do that. We can incent health management, and we do that through a program that we have in our CDHP plan I'll talk about just in a second. We can eliminate real or perceived barriers to care. Sometimes people are afraid because they think they're going to have more out-of-pocket costs and don't understand that they won't. And then, like I said, we do and can foster accessing preventive care. Just a second on a way that we, within our consumer-directed health plan, incented chronic care management. We rolled our plan out in 2003, so we were one of the early adopters. And as we saw it and we saw people were looking at it, we realized that there were two things. There was a financial difference between the cost, out-of-pocket cost for members who had chronic care in that plan. And there was a perceived fear factor, as well as we were concerned that they might make a bad decision because people think, I've got money in my health reimbursement account, I don't want to spend it because I'm afraid my kid's going to get a sore throat and they're going to need to go to the doctor. So they might make bad trade-offs. So we worked with our health plan and created something that's now called Rewards for Action. And basically, if you have one of a half a dozen different chronic conditions where there's evidence-based medicine, we know what the right thing to do is. If you are doing the right thing for that care, we'll put money back into your health reimbursement account. If you're getting education about your condition, if you're going to the doctor when you're supposed to, you're getting your recommended care, we'll put money back in. If you know your numbers, because that's a part of the equation, knowing what your blood pressure is and your HbA1c is. If you're getting your prescriptions filled and taking them, we'll put money back in. So you can get back almost the full, quote, deductible or out-of-pocket cost into this plan by doing the things that you should be doing for yourself. We found that it works. People do take advantage of it, and the ones who do take advantage of it, they do have better outcomes. Unfortunately, not everybody has access to it in that plan, and not everybody does it. Americans we're just lazy about these things. We know that if we pick a good plan and we work it well, we can end up with impacting healthcare costs and with better outcomes. We know that, we know our team members are using the tools that they have access to, as rudimentary as they are, they do access them and use them. But the problem is, and I just got my first peek at my renewals for next year, it's the train wreck that started the day. It's just a train wreck. And it's very difficult. In my role, it's very difficult. So we're just a little piece. The panels have talked about other things that have to happen. Health information technology, we've got to use that as the linchpin to get the information together so that we can have the transparency so that the consumer can learn and we can all eliminate the waste and get to the better quality. We've got to get a reduction of provider errors, and we've got to get all the payment systems aligned. We can't do it alone. We need a national solution. And I don't have these words on this slide, but I do want to point this out, and it's inherent that I use the word, or it's important that I'm using the word national solution. There are some very laudable experiments going on in various states and cities. I come from San Francisco. There are some very laudable experiments, but as a company that has employees in all 50 states and hundreds of cities, state by state, city by city solutions are not tenable for us. They're laudable, but not tenable. We have to have national solutions, and that's going to mean we have to have support for preemption of these kind of changes through ERISA. I don't think I'll even spend any time on this slide. I think we've talked about all these solutions as a group. We've talked about they are actually solving for the things that we see as the barriers to care. We can work together to get to a good solution for all of us.
Thank you very much, Sally. Louise Malone.
It is true that as an administrator of a Taft-Hartley fund, we pay the bills, but we come from a slightly different perspective than the employer because we work with both the employer and with the union and exist for the members. And so this group of workers that I'm going to be talking about today, if I can find the enter key here, are low-wage workers, and they literally fall through a chasm in the healthcare system such as it is. They basically are also, many of them, in a spiral where their health care is just creating misery for their quality of life. So I'm going to go through this a little bit quickly. This is just healthcare information that I think we all know. We were originally set up to deal with these three types of workers: child care workers, home care workers, and janitors. These child care workers and home care workers actually have no traditional employer. They are technically employed by the clients they work for. The janitors do have traditional employers. The average income before organizing for the janitors was somewhere around $6 to $6.50 an hour. The vast majority of them working part-time, most of them having 2 or 3 jobs. And by part-time, I mean 16 hours a week. They have no sick leave, no vacation leave, no personal leave. The child care workers, that's $9 to $20 per child care day. And that is paid on a 1099 and does not include the amount of money they have to spend to provide the services that they provide. And in addition to that, our members are an insurer's nightmare. So the average age is 45 to 48 years old. They're 80 to 90% plus female. They are largely minority, some rural Caucasian. About 100 languages are spoken in our union. They have inconsistent or no previous health care, usually no. They have multiple untreated chronic diseases. They also have a whole list of undiagnosed cervical cancers, breast cancers, endometrial cancers, congestive heart failure. They have learned how to use the ER as their doctor, and they have learned how to do it with a creativity that blew my mind when I started talking to them. It was brilliant. So, you know, and just as an example, in one bargaining unit of 37,000 home care workers, we surveyed them, and 45% of them self-identified as having chronic disease. So So here's the other, set of our challenges. Why are they low cost today? Because the employers are in highly competitive situations. This is a workforce, especially with the janitors, that is very mobile, high turnover, so we get little or no money for their health care. The money that we do get leaves them grossly underinsured, something that Senator Daschle talked about quite a bit in his book. And if they have insurance, they simply can't afford the co-pays or the co-insurances. And I'll give you an example. I was talking to some Head Start workers in Jacksonville, had the highest ER incidence I had ever seen. They had $25 physician co-pays, and I said, why are you going to the ER? Because if we go to the ER with an insurance card, we don't have to pay anything up front. We just deal with the bill later. So that's why 59% of our future high-cost population comes from today's low-cost population. So, our philosophy is that we can't do it all with $175 PMPM, which is usually what we get. But we do want to try to treat chronic disease. We do want to make it easy to see the doctor to get that done. We do want to have at least some drug coverage and diagnostic coverage to the extent that we can. We shortchange hospitalization, and so these folks face huge bills if they end up with an acute problem. But we do give them first dollar coverage, no deductible. We found that even a $100 deductible for our members makes it impossible for them to utilize services after preventive care. So if we're going to walk the walk that Andy Stern and Anna Berger and our leadership talk, we have to look seriously at evidence-based medicine. We have to encourage personal responsibility. We have to address chronic disease as creatively as possible. And we have to realistically address smoking and weight control, which are obviously, we all know, are major drivers here. Why try value-based insurance design? Because it overlays quality of life on the calculation of evidence-based medicine. It differentiates co-payments based on the actual value of the service, both to the system and to the individual, and because it will help us drive patients into essential services. Our partners in this are the University of Michigan, Dr. Mark Fendrick, who's been great, United Healthcare, and two of our janitor locals, SEIU Local 1 and 26. Our members are on limited plans due to financing, and we've already gone through a lot of this, so I'll move along here. Without going into a lot of this detail, basically what we're going to be doing is using health risk assessments, biometric screening, and incentives to get people to go ahead and get their preventive medicine. From that, we're going to move them into two groups, and that will be one group that's relatively healthy but may have some weight control issues, some smoking issues. We'll zero out the cost for them to take care of those issues. We'll provide telephonic coaching because we know people don't have time to go to meetings. If they do have either diabetes, high blood pressure, or asthma, we're going to begin with those three disease functions, and what we're going to do is zero-tier their drugs and zero-tier their services. And the drugs are zero-tiered whether they're generic or brand if the outcomes that we've seen on those drugs make them worth the cost to us. So that's pretty much what we're going to do. I have more detailed information on that if you want it. This goes into some more of that work. And the questions we're trying to answer, we know the local leadership is receptive. We've checked that out. The members, we recognize that we're going to have to do serious education. We may have to upgrade this. The employers have basically said to us that we've talked to so far, go for it, just don't let it cost us any more money than it already does, because frankly that is anti-competitive for them. And how do we deal with it with limited coverage? We're working on it. The United Healthcare has come to the table on this. We're going to do this with a small group of workers initially, and they are going to manually adjudicate those claims. That obviously is not a way forward in the future for this, so we're all working together to figure that out. And we have actual data on this group of workers in Milwaukee and Minnesota from previous years, so we will have an opportunity to evaluate what the differences are through utilization data, surveys, health risk assessments. And this is what we're hoping will happen. We're also working with some additional folks about how do we do this for people with more money, more comprehensive plans. Can we come up with value for the money? And As we look at this, what would be important policy considerations for this group of people? Well, obviously, if your employer is your Medicaid client, severing health care, creating a universal plan that severs it from employment is extremely important to these workers. Affordability is important, but affordability has to have predictability with it. If a worker in this group goes into a health care provider and they come out and they've had to pay $85, they're not going back again until they're really, really sick. Obviously, electronic medical records would be extremely important for this group of workers, making it much easier to follow them from situation to situation. We are also experimenting with a couple of clinic models for workers, and in those situations, we're going to be heavily reliant on NPs, making sure that NPs can do the work that they need to do and on a regulatory basis, and changing some of those regulations so that it's pretty even from state to state and that they can provide scripts is very important. And I think that's it. Did I hit my 7 minutes?
I think you did well. Thank you. Thank you very much. Pat Kapos-Larson.
Good morning, or early afternoon, as the case may be here shortly. It is with great pleasure that I represent Evercare, a fully owned subsidiary of United Healthcare, who we've been hearing about, and we're so appreciative of having this opportunity to be here today. Also want to acknowledge that I am a nurse practitioner by background, and part of the reason for my attendance today is at the behest of the American Academy of Nursing, that has recognized the model that I'll be presenting to you as one of the leading nurse-led innovations in healthcare delivery in the country today, and we thank them for that acknowledgement. Evercare is, first and foremost, a model of care delivery that was first designed in 1987, so we have some history. It was designed in order to address, at that point in time, the issues surrounding those very frail, vulnerable, complex people who were choosing to live out their lives in long-term care facilities. And because of where they were being underserved by the healthcare system. What was resulting was poor quality, oftentimes a shortened lifespan, secondary to the implications of the type of care that they received. They were seeing healthcare providers only as it was mandated under regulation, and not anyone who was focused at proactive, preventative, thoughtful planning for their care. The answer to this, as I indicated, was the envisionment and the moving forward of a company known as Evercare, founded by two nurse practitioners who believed that there could be and should be a different way of delivering care. The work that was accomplished in our early years as part of a Medicare demonstration project, ultimately in 2003, laid the foundation for us and others to begin offering many of the benefits of the kinds of health care that we were providing and the plans that we had developed to a broader community of individuals living with chronic, complex diseases, but now located in the community. And that was first the embodiment and the envisionment of the special needs health plans. The premise of Evercare is fairly simplistic, and that should not mitigate the impact of what can happen if you pay attention to evolving benefits, products, and services built on these premises. And first and foremost, we've heard a lot today about the acute care setting and what it may provide, what it will not and cannot provide, and particularly noting that for individuals who are very frail, very complex, the acute care setting is often inaccessible to them or will result in negative impacts. We also believe very strongly and continue to have this validated every day that you truly need to align incentives. Incentives financially have to, in fact, be related to performance and the driving of value, the driving of outcomes. And lastly, that care should and must be ongoing, it must be coordinated, and there must be an undergirding of communication methodologies to ensure the smoothness of that care and the equity across the healthcare system. Our mission is optimization of health, and we believe that every person, irregardless of how frail or how complex they are, as we meet them and engage with them, there is an opportunity to establish an optimal health level and to maximize their well-being. We are, as noted, a company founded and driven by nurse practitioners. We employ nurse practitioners, and they serve and function for us in multiple roles. In addition to being extremely astute clinicians whose competencies are continually assessed and reassessed, they also must perform the roles of collaborator, coordinator, advocate or coach, and often that of a counselor. They become the center, the foundation of the formulation of a multidisciplinary, multi-focused, sometimes even a virtual team. We charge our nurse practitioners and work with them on having the ability to closely monitor changes in individuals and trying to identify the change as early as possible in order to escalate and alter interventions in order to address the change before it becomes substantive and highly disruptive. They are constantly, therefore, focused on a reduction in fragmentation of care and focused on assuring that the care that is delivered meets the needs, wants, and desires of the individual. In order to do this, they engage families, they engage nursing home staffs, and they engage the wide array of health professionals that we need. As you can see from this slide, which I won't spend a lot of time, the concepts that we purport and the benefits we offer have allowed us to grow nationally and now be present in 38 states, to serve people with multiple populations and collect data, information, and evidence on those individuals, which we believe will help inform healthcare delivery as we go forward. We have proven internal and external validation of what we do every day, not only in the decrease in hospital admissions of these very complex individuals, but we have also been able to identify and validate year over year improvement in well-being and a decrease in mortality. We have satisfaction on multiple levels that I think is important and vital to consumers, and we have engaged at the state level in order to look at nursing home placements and support people to remain within their community. Barriers along the way have really been focused on the ability of people to understand and engage around chronic illness that people are living with every day, but more importantly, what it is like and what needs to happen in a healthcare system that will deal with many people having 3, 4, and 5 illness states compounding their complexity. We have faced and continue to deal with a lack of staff and individuals who understand complexity, who understand critical thinking, who understand geriatrics and long-term care management. We really believe, and you've heard this from others this morning, our system, and I use that in quotes, is and continues to be fragmented, and there is opportunity. We truly support and believe that there must be policy and initiatives that support innovative care models such as Evercare to provide evidence and inform decision-making go forward. We believe there is a role for the special needs health plans and look for an opportunity to validate that, to explore that, and to move that forward. We also believe, which the last couple bullets address here, in the information released last week in the IOM report, and that as we look at our shifting demographics, We believe that there will be and there needs to be public support, policy support, and funding to create new roles in the healthcare arena, to expand the roles that already exist, and to assure that people are adequately reimbursed and focused in the areas that they need to be focused on for performing the very best for our public today. Thank you.
Thank you very much, Pat, for that excellent presentation, and to each of our panelists for giving us their thoughts on the benefit designs that maximize good health care today. And I can say without equivocation, this has just been an extraordinary morning, discussion of very, very good ideas. I'm going to call on Mark and Chris for some final comment, and I'll have a few words to say, but I want to thank all of our panelists. But let me begin for his closing remarks, Mark McLeod.
Thanks, Senator, and thanks for your role in organizing and leading this effort. You know, when we were putting together this forum, we wanted to go below the very concerning numbers about healthcare costs, about the gaps in the quality of the care, and as a result, the health that our country is obtaining. And I have to say, I'm very impressed with the depth of the dive that all of our panelists took. It's a bit longer dive in some cases, and I want to come back at the end of my remarks to how we're looking for more input from all of you who are here today, all of you who are viewing the webcast or following our efforts in other ways. We want more input on this, but I have to say, you know, when you talk about healthcare finances and these general statistics, it can be a little bit dry. When you hear about the dedication, the effort of people who are putting their life's work into changing the way that healthcare operates, and in some cases doing it successfully despite some very big obstacles, that level of passion really gives me encouragement that the efforts that we're undertaking now are going to amount to something. I think it's going to amount to something on the provider side. The health professionals who you heard from here today, those who are involved in healthcare delivery and medical innovation in one way or another, clearly have some better ideas that are starting to work to make a difference in these trends. As Denny said, we don't have a healthcare system now in general, but we sure have the makings of some, whether it's real healthcare systems and pieces of healthcare delivery, or virtual systems where providers and others are working together in new ways. Some of these are provider-led, some of these are insurer-led, some of these are employer-led efforts, and importantly, many are consumer-led, and that's all very encouraging. And also was struck by the across-the-board emphasis on consumers and individuals here, not just from the standpoint of the role that they can take if we support them in getting to better care, but also the potential for public concern about the kinds of issues that we discussed today. Not just that these are big challenges in our healthcare system, but that there is a way to change it. There are steps that you heard about now that consumers can be involved in, that all of us can be involved in, and I think there's a real potential for added public momentum behind the efforts of this group with BPC and all of you who are working on our common challenges of getting to a much better healthcare system. And I was also struck by the similarity in many of the comments that we were hearing from many different perspectives. There seemed to be quite broad agreement that we need to get much better information through electronic means, but that the end is very clear. Much better information on outcomes, safety, service, and cost. As Denny put it, didn't hear anyone calling for or saying that wasn't a high priority, because that gets us to value. That gets us to an ability to support all of these efforts much more effectively, and it can happen. It is difficult. We've got, as Chris said, rudimentary systems in place now, but there are ways to build much better on that, and you saw examples of that in many of the presentations today. With a much better system of information to help us focus on what really matters, there clearly are ways to move towards paying better for value, towards designing benefits to support value. Everyone, I think, said we need to move away from the current payment systems based on fee-for-service, and we need to do it carefully with accounting for the needs of especially the vulnerable populations that many of these programs serve. But I've heard very consistent calls for changes in the way that we pay, changes in the way that benefits are designed, not based on some theory, but based on efforts that are being undertaken right now to get consumers more involved in their care and to support providers when they have these really good, passionate ideas about how they can make healthcare work better. That will get us to more individualized, effective, prevention-oriented care. It will get us to more coordinated care for diseases, and one of the things that we will be undertaking as a follow-on to this effort is helping to turn some of these ideas into better evidence on the kind of impacts that successful implementation of these steps can have on the cost and quality of our healthcare system, and to use that as a way of supporting the efforts to get to affordable, high-quality care for everyone. Our future forums will take up issues like how to do this in conjunction with financing reforms and other reforms to involve individuals and the like. But we have a very strong foundation thanks to the discussion today. Also, I think many people emphasize that with this greater emphasis on quality, on cost, on value, it will help push towards the kind of better evidence system that we need with transparency, with learning, to help get to care that continuously gets better. And while many of these efforts are not being led by the federal government, I think several people noted that Medicare, while in the 1960s it might have been appropriate in the legislation to say that it shouldn't have any effect on the current system, at this point having no effect on the system of the 1960s is putting us 40 years behind where we need to be. So we will be looking at ways to try to help Medicare support the kinds of leadership that we've seen from throughout the private sector and from programs that are serving publicly served populations here today. There are going to be, as I mentioned at the start of my remarks, more opportunities for input. Many of you who are here today, I know, are leading efforts like the ones that we heard about today, moving in the same direction towards better quality, better value, providers who can get much more out of the time and effort they put into the system, and consumers who are better served by it through their active involvement. We will have future forums. The staff of the BPC, led by Matt Kennedy, will be holding more meetings, and we will be supporting more analysis. And I'd encourage you to follow up with Matt, as well as keep in touch with us as those opportunities unfold and those discussions continue over the months ahead. But most of all, thank you all for your passion and your commitment to taking on this very difficult challenge of getting to a high-value healthcare system. I feel like we've got a lot of momentum for our efforts thanks to your leadership.
Thank you very much, Mark. Excellent. Excellent comment. Chris Jennings.
Thank you, Senator. I'll be brief because Mark took everything I was going to say. No. Well, I think, first of all, I want to thank all the speakers and the presenters. It was just an extraordinary morning, and the contributions they made, I think, are really, to put it lightly, stellar. And I want to say that what we have learned, I think, most of all, is that when we talk about this issue of coverage and affordability, and we talk about the sort of, we need to have a nexus of those two and quality, I think it's becoming more and more clear that the unifying principle, and indeed I think the pivot point on all three, is going to be quality. It is the issue, quality and value, that brings everyone in this room together from all the perspectives that we see. And in fact, if we don't address that issue, value and quality, then there will not be confidence about moving the system forward and about having an appropriate investments in it to make it work. So for that, I want to thank you very, very much for that. I think it's quite clear, not only is that the case, that the people who've come in, who have and will contribute to this, have not done it just for altruistic reasons. They've done it for survivability and sustainability reasons going forward. And for that, I have great confidence and optimism that we are headed in the right direction. I'm going to conclude just with an appeal, which is, you know, if only the debate was made up of people in this room, I think we would feel very, very good and we would get things done. We all know, although it's open and available and accessible to all in this process, There will be naysayers, there will be cynics, there will be doubters. And the truth is, there are legitimate questions that are raised. And I think what's exciting about the panels that have been presented to us today is there's some real data, there's some real analysis, and some substantive recommendations that can move us ahead. But there are more difficult questions to be answered. And as we move forward, I hope you will help answer those questions for us in ways that are relevant to the policymakers in Washington to accelerate the process that you have laid out, that you have shown can be done, in ways that are both policy sound and politically viable. And to the extent that you do, I am greatly confident that the 4 senators that we have the honor of serving will be able to make some very solid recommendations to go forward. With that, I'll conclude. Thank you.
Thank you. Well, let me simply reiterate our profound gratitude to each of the panelists who've come today. I think it's been an extraordinarily enlightening morning. And as both of them have noted, this is just the beginning. We hope that we can continue to build on the information provided, the dialogue that has been so much in evidence today as we have considered some of the toughest questions involving quality and value. And so I'm grateful especially to each of you for your participation. Today's proceedings will actually be available later on this afternoon on the Henry J. Kaiser Family Foundation homepage. That's kaisernetwork.org as streaming video. So we hope that you'll encourage your colleagues, those who couldn't come, to check that website. And then also check back on the BPC website later today and through the week, because we will be posting updates on the project and additional information about our next forum in this series that we anticipate will be held sometime in June. I would also note that I think that there was sort of a wonderful thing that I saw coming today that I think defies the perception about this issue and this challenge, and that is that the disparate participation among groups will never allow a consensus on these issues. Well, I heard a lot of consensus today, and I think Mark and Chris really touched on many of those areas where there is great potential for consensus. We've had businesses, labor, professional organizations, providers, in other words, all participants, categories of participants working in a way that I think gives me more hope and a real sense of optimism about the possibility to build on the kind of dialogue that we experience today. And that's really what the BPC project is all about, is to build on what we think could be consensus approaches to many of these issues. And I hope we can continue to demonstrate that. The BPC is now hosting a lunch immediately following our conference to honor our speakers and organizers, but we sure hope that you'll continue to participate, to give us your thoughts, to consider this the beginning and not the end, and to continue to build on the consensus that I think we could find as we work through these very challenging issues. Thank you all very much for coming, and we'll retire now to the lunch.